Professor Kamran Chima. Professor Kamran Chima is the best graduate of King Edward Medical University of the year 1986. He is professor of pulmonology at Services Institute of Medical Sciences, and he is heading the state-of-art ICU at SIMS. Before we go to Professor Kamran Chima, we are very grateful to our chief guest, Shafqat Mahmood Saab, and Madam Professor of Gynae herself. But we are very grateful for your participation, and it was a source of encouragement for us, Madam and Sir both. And we are very grateful for this.
I wanted to pass a comment. Thank you so much. I'll sit on till I can, and I'll then quietly excuse myself. I'm extremely grateful that I'm participating in this webinar. I'm sure there are plenty of information, but the minute I feel that I have another commitment, I'll just quietly go away. And I'm extremely grateful for the tremendous effort that you people have made. Thank you so much.
I'll go back to Professor Kamran Chima Saab.
Thank you, Professor Bilkis and Vice Chancellor Saab for inviting me here. And I have a very different perspective on this because I'm seeing patients in the government sector, and I'm one of those who are still seeing patients in the private sector and dealing with a lot of patients on phone, WhatsApp, etc. My take on this disease is a little different from the official figures. I am seeing people coming to the hospital with suffocation and dying before we could even put them on ventilators. And those deaths are probably not all of them are not being counted. And when I talk to my patients and obtain histories from them, I find it's not uncommon that they've had some relative in the family who died. So here's someone with a proven case of COVID pneumonia, and you talk to them and you find out they lost a relative. And everybody attended the funeral. Nobody actually thought that that person died of corona. So I think we are in a false sense of security that we will have a low mortality. Unfortunately, I think the mortality here is going to be the same as in some other countries. I do think that we need to focus in our resources on oxygen therapy. It costs about 10,000 rupees to have a couple of flow meters per patient, and copper piping and having central oxygen. Ventilator is much more expensive. We could have as many ventilators. It would really not make a difference if we didn't have a team. In my own center, I tried to set up a very good unit with the latest ventilators and my team of doctors, but our results when we were ventilating corona patients were very dismal. We were losing patients, so we stopped actually putting them on ventilators until there was no choice left. Then finally in a meeting, Madam Minister was very kind. She gave us some nursing that we had been hoping to get, and our results changed. So we successfully started extubating patients. The same team of doctors with the latest ventilators was unable to do that till we had all the support staff we needed. And that would be very difficult. So I think we need to focus more on just providing a lot of oxygen therapy to patients. And it's very easy to do that, converting hospitals into units with oxygen, central oxygen. And that is the most cost-effective way to deal with this problem. And I think the more, when we talk about tocilizumab and remdesivir and those kind of therapies, which are very, very expensive, yes, they have a role, but I think the government's money is best spent by providing oxygen therapy and maybe finding if there is a dedicated team of youngsters who are willing to do some volunteer work here. I know that some force was raised. There was a Prime Minister's Tiger Force. I don't know what happened to that force. I would love if some young, dedicated volunteers were ready to help these patients, because I see my patients both in the government sector and in the private sector dying a very lonely death. I have recently lost my own uncle, my real uncle, Professor Ijaz Hassan, who was former principal of KE, due to a complication of COVID. And I have seen how these patients, they are deprived even of human touch, because even he was my uncle, I would go in, I would be covered, and the patients, I thought, were lonely, and I don't know what to do about it. And I think we need volunteers who are preferably younger, who think that they want to go and spend some time with such patients, because going into those units is very, very depressing. You go into a unit, all you see are patients on oxygen, gasping for air. There's a lot of compassion fatigue, actually, that I see setting in. I have seen residents after nights in the emergency crying because they can't put up with that. So I think that this is a real challenge for our healthcare workers. And I think we should focus our limited resources to the most effective area, and that would be to provide oxygen therapy, if nothing else. Ventilators, yes, very good, but those require a lot of staff to support, which we may or may not have. And honestly, they don't make a difference unless you have a very good team to take care of them. And teams take time to develop. Thank you.
Thank you, sir. And we really appreciate your effort, and we share this sorrowful departure of your uncle. He was not only your uncle, but he was teacher of teachers, a legend in surgery, and on a personal note, a very close friend of my father. So soon at the end of the session, we'll be saying Fatiha for him and all the dear departed. Thank you so much, sir, for your words of wisdom. Now I'll request Professor Zafar Iqbal, Professor of Critical Care Medicine and Anesthesia, Medical College of Wisconsin, USA, to kindly join us.
Honorable Chief Guest and Patron-in-Chief and the Chief Organizer and my fellow participants, Assalamu alaikum. So I am a graduate of King Edward in 1987. So I will talk in a very different perspective that probably would not fit in our country that much, but still I want to talk it because of the limited resources in our country, as Professor Chima has talked about it very well, So I was running ICU, that's the COVID ICU. As you know, the way the patients we were managing, so patient comes in with hypoxia, shortness of breath, oxygen in some form, supplemental oxygen, and then high flow oxygen, prone positioning, BiPAP, CPAP. And then after that, because there was plenty of resources over here to put on the ventilator, we have a dedicated team. But even then, we have a very high mortality rate. We were putting the patient on ventilator, very dedicated team under my supervision. But still, we were having a very high mortality rate. And then we sat down and then we said, what's going on? We are putting the patients after all these non-invasive trial of oxygen that we give and proning and vapotherm, BiPAP, CPAP. So we decided and we made a criteria to put the patient, instead of ventilator, putting on the ECMO. So what is ECMO is basically, it's just like a heart-lung machine. Principle is that you can bypass the heart or the lung, meanwhile you give the time to recover them. So, and it is not very big like a heart-lung machine. It's a portable that we used. It's a portable machine, and you can either bypass the lung or the heart. So we decided that we can bypass the lung. Meanwhile, we give the time to the lungs to recover from this ARDS, and then we should do it. And we did it before we were doing it after the ventilator. When the patient is not making recovery on the ventilator, we put the patient on the ECMO. Absolutely very, very devastating and discouraging results. Now we changed the criteria and we said we're not going to put the patient on the ventilator. Rather, what we will do, if we get to that point, that patient should be on ventilator, he cannot maintain his breathing on his own, he need a support. Instead of that, we will putting on ventilator, we will put him on ECMO. So, but we made some criteria that why was so mortality rate was so high when we changed from ventilator to the ECMO. We thought that these patients, when they were on ventilator, they had some cardiac event, they were on inotropes, they have a failing liver, they have a failing kidney. So that was not the good time now to take the patient from ventilator to the ECMO. So we decided when the patient needs oxygenation and he cannot oxygenate himself with the help of any vapotherm supplemental oxygen, instead of putting on ventilator, we will go to the ECMO. And we made the criteria: age should be less than 65 years, and he should not have any comorbid condition, like example, dementia, cerebrovascular accident, cardiac event, like he's not on bunch of inotropes. He should not have a renal failure or a liver failure. He should not have any malignancy that he's on immunosuppression. So we put this patient on ECMO. The results were very encouraging, and I was so pleased with the results that compared to previously, now you can say that these are the patients who will recover anyway. So what about the results are so good? No, but these are the patients who will end up on ventilator otherwise. So we put them on ECMO rather than on ventilator. And the results were much better compared to when we were putting the patient on the ventilator. And so that's that we learned. If we put them earlier on rather than putting on ventilator and then transition them to the ECMO that we usually do on for some other reason. And surprisingly, the results were very encouraging, although this is, as I said, over here, a lot of resources, you have everything available. But I just want to run this by. And one of the patient, when he needed this, we put him on an ECMO. We put a cannula, divert the blood to the ECMO and oxygenate it, put it back. The patient was able to ambulate. And he was talking while his kidneys were being oxygenated through the ECMO. And we had a very good results. But overall, as nationwide, when the pandemic is over, the results will be put together. We will know that what's actually made the difference. But right now, that's the policy and the criteria. We are using it, and we have a very, very promising results about it. Thank you very much.
I just wanted to know whether you would prefer invasive versus non-invasive.
Oh, yes, I would prefer non-invasive, because invasive ventilation, putting the patient on ventilator, did not take us anywhere, really. So non-invasive, yes, the best way. Vapotherm, proning, yes, made the difference, and then as professor was telling too, and we can use it, vapotherm, high flow oxygen, supplemental oxygen, that is absolutely, I would say in my experience is better.
Madam Minister said that Mayo Hospital is catering for more than 400 patients, and this is exactly our observation, that the patients with put on non-invasive therapy, they recover much better as compared.
They recover much better. That's what we initially made the mistake. Exactly. I think we were putting on ventilator. We have plenty of ventilators, steam, and then putting an ECMO. There's no good results. But then I said, no, don't put on the ventilator. Ventilator associated pneumonia and other problems. Just put an ECMO if you have. Otherwise, non-invasive was much better than that.
Exactly. Thank you so much, sir, for this very valuable information. I just saw Madam Yasmin Rashid talking on the phone, and I fear that she might be leaving. My next question was from the cardiologist, but Madam, with your permission, may I ask you something as a gynecologist?
Most important factors that a lot of people have been not really looking at is that there are women who are pregnant and who are also COVID positive, and I've shared this experience with other doctors also. But what we did right in the beginning is we assigned a hospital separately for COVID pregnant patients, like Gangaram Hospital in Lahore is trying to look after the majority of the COVID patients. And Alhamdulillah, over the last 2 months, they have delivered nearly about 50 patients normally, and they've done cesarean sections successfully on COVID positive patients. And that is something that we really need to do, is that every city needs to have a dedicated hospital, particularly for pregnant patients. And they should have a protocol, because you can't, since now we have COVID all around, you can't really ignore this group of patients which are most vulnerable. Number one, the added advantage that they have is that they're young women, and normally they are healthy women who are all pregnant. So I think we must take an extra opportunity to really help them out and ensure that they have a safe delivery, so that they can cope up with the situation. So we are trying our level best, and I think this is something that I would love to have an input in it. If anybody who's working in gynae, in any people who are a part of our webinar, if they are working in a gynae department, I'd like to know what are they doing internationally.
We see that they recover very well. Because probably, as you said, they don't have, usually they are in the age group where they are not having pre-existing diseases. Generally, their recovery rate is very well. Madam, since this webinar is also being attended by the postgraduate residents and our students, I'd like to ask one question for my own knowledge as well. What about the vertical transmission of the virus? What is exactly the, is it a gray zone as to whether it is vertically transmitted, or is it clear that it is not, or what?
The number of papers which have come out, as people are bringing out papers, is particularly where even if a mother is COVID positive, uh, at the moment, vertical transmission as such has not been seen. What is the good part is that they're encouraging COVID positive mothers even to feed their babies by wearing a mask, and ensuring that they can feed the babies, because feeding a baby is extremely important. And by the time, as we see that the normal period that a COVID patient has lasts for about 2 weeks or so, a couple of weeks. So what is normally done is that mothers are encouraged to bond with their children until and unless, of course, they're severely ill. If they're very mild symptoms and they can deal with it and they're COVID positive, then they are definitely encouraged to bond with their babies, to feed their babies. So basically, the thing is this, that we are learning. It's a learning curve for everyone in the world. It's not only in Pakistan, anywhere in the world, people are learning, and every day you have a new experience coming up where pregnant patients are coming up. But as you said, of course, I know the patients are being delivered in Lady Wellington Hospital, but particularly because people were a little scared initially, the medical professionals were also a little apprehensive. Therefore, we dedicated one particular hospital so that we could reduce the burden on other hospitals. But now, gradually, I think what is very encouraging is that our medical professionals are dealing better and better with these sort of emergencies, and hopefully, inshallah, we will be doing a much better job looking after all these pregnant patients with new papers that are going to come up. We would have nothing definite as yet, and I'm sure there's going to be lots and lots of research which will have to be done before we really come out whether there is any vertical transmission, or frankly speaking, if it's transmitted from the mother to the baby because of the close proximity. And then hopefully if a mother develops antibodies while she's feeding the baby, would those antibodies be helpful towards protecting the child? All these have to be seen. Thank you.
Thank you
Professor,
so much, madam. Thank you.
just make a very quick comment if I'm allowed?
Yeah, sure.
I'm not sure if there are any pediatricians on this webinar, but there have been
Yes.
reports in the UK where a multi-system inflammatory syndrome was seen among the pediatric patients. It was a very, very rare occurrence, but it was a bit like Kawasaki syndrome. And there was a recommendation that we should monitor and be vigilant. Thank you.
I'll invite Dr. Aisha Shabir. We are very lucky to have best graduates on the forum today. She is the best graduate of King Edward Medical College at that time. Dr. Aisha Shabir, you are practicing as a pediatrician in the city of New Jersey. In the city of New Jersey. In the city of New Jersey. and medical group out of Hoboken, Bayonne, New Jersey. And this is right across Manhattan, you said, and this is important to mention because Manhattan and New York face the maximum number of cases in USA. So, Madam Aisha Shabir, would you like to share your experience regarding this?
Assalamu alaikum. Thank you so much for having me on this forum. Thank you so much. I am going to deliver the happiest part of this forum, I think. The best outcomes for pediatric patients, the least complications were with the pediatric patients. There's still no proven vertical transmission. People can breastfeed, but at the same time, there's so much unknown that all the pregnant healthcare providers have been put on telemed only. So that right there tells you they don't know a whole lot about this. Now, since March, I think we tested 15,000 babies or children under 21. 60% were asymptomatic carriers. They were checked only because their family members were sick. Now, less than 0.6% actually got hospitalized. The other different categories, it was like from runny nose to rashes to Kawasaki-like syndrome, which was only 100 to 150 cases in this area, to diarrhea, to stomach pains, to nothing else, actually. Red eyes, and just the most vague symptoms that you can imagine. You can throw 5% in each category. As you know, there's no known treatment. You just prevent yourself from getting it. The biggest thing that got everybody's attention was Kawasaki-like syndrome. The youngest that I've seen was 6 weeks old, was from the Hoboken area. Now, Hoboken is known for having all the European, highly educated people. At the same time, they resist treatment. So this one child was 6 weeks old, was seen multiple times on telemed, in office, here and there, and was resisting going in for treatment, for testing, and ended up having the most complicated case that I've seen so far. Again, the recovery was excellent because all systems are new. They do just really well. Despite all the trauma to this baby, came out just fine, no coronary aneurysms. Was really scary for a while. Everybody was, panicking about it. But again, the outcome was really good. Now, over time, over the next so many years, he's gonna have a multi-million-dollar workup done, be followed up. And I'm not sure, to be honest, even if the mother had listened to everyone and gone in, if the outcome was gonna be any different. But I'm on the happiest end of this disease.
Dr. Aisha, since we have many students with us on board as well on this forum, can you describe what KEMU means and how it manifests as?
So it's like more than, okay, first of all, you have either subjective fever or documented fever more than 38 centigrade. Now for Kawasaki, we have to have more than 5 days of unexplained fever, no other known etiology. In this case, it can present a little bit sooner. You have the red eyes, injected conjunctiva, you have the cracked lips, you have the strawberry tongue. With Kawasaki, you have the one swollen lymph node in the neck. And then you have the rash that affects their hands, the fingertips are peeling off, the nails are affected. Now, back in November and December, I saw some children who looked like more like what you call Kawasaki disease, hand, foot, and mouth disease. But looking back, that could have been COVID. Those people did have positive antibodies with no other illness since November. So I feel like this has been lurking around longer than I think it was. So again, for Kawasaki disease, there's some lab findings that are different between Kawasaki's and this COVID-related similar syndrome, like the lymphocytes and the platelets and the recovery. But the one alarming thing is this causes more myocarditis, and Kawasaki was more focused on coronaries. Like you look for aneurysms and complications from that, but this one has caused more myocarditis, like symptoms, which is more dangerous. Now, again, one other point that somebody else pointed out was you give IVIG. Again, it might not affect your outcome in the end, but you have to be careful not to give aspirin with COVID-like, COVID-related complications because of the whole liver being affected. So that's one thing they're focusing on. Again, massive use of antibiotics, massive use of immunoglobulins and steroids, but be careful with aspirin.
All right. So, so I do think that the age affects the manifestations of the disease, because we are not seeing such rash and such like probably our cardiologist, who's the next speaker, would comment on it better. But we are not seeing rash in our adult patients.
No, you're not going to see that. Yeah, you're not going to see that.
There's something else I want to share, because you are living right next to Manhattan. And as everybody knows that New York and New Jersey face the maximum number of patients, and there was a very strict lockdown. How would you describe that lockdown? Since you're living over there, we just want to share that experience.
Okay, so from March, from denial.
Dr. Aisha, we can't see your face. We can't see your face.
Because I'm on phone. Okay, now you can see it? That's enough. Yeah. Okay. So from excitement, from denial to excitement to being actually following the lockdown. So now they have actually some kind of emotional fatigue going on. They just don't care anymore. I was on a plane last night, and just as we were about to board, some family got off the plane and the father was trying to suffocate the child because she was coughing so much. And immediately that gives you a response from everyone. So that's wrong. So the screening methods they're using, the temperature check and the screening methods are not working. People are becoming more dismissive. I think they're depressed about being, and Dr. Hashmi is going to touch that part. I'm not going to touch that part, but I think there's a lot of like emotional fatigue with the lockdown. So the peak of the curve that was hammered down is actually going to show up again. I feel like this coming July and August is going to be fine. And September, October, November are the big challenging months coming up. Whoever did not get it is going to get it. They are going to make it, but they might be the ones who carry this virus to other family members that live with them. And as we know, some are really high risk. Personally, I had my mother with me, and I was literally boiling myself before I went and saw her. I mean, my skin is coming off. That's how much I disinfected. But I feel like even I am getting tired of that. So there's a lot of, there are a lot of emotional issues attached to this lockdown, and that's why you're going to see a second peak. Or a third
so we are eagerly waiting for Dr. Hashmi to speak on this.
Yes.
Thank you so much, Dr. Aisha. And speaker is going to be our cardiologist, Dr. Amir Shabir. As I said, Pakistani doctors are the best all over the world. He's the second best graduate of King Edward Medical College at that time of the year 1990. He is interventional cardiologist, founding member of Cardiac Consultants of Central Georgia, diplomat, American Board of Internal Medicine and Cardiovascular Diseases and Interventional Cardiology. Dr. Amir, what is your observation on corona-related cardiovascular morbidity and mortality?
Yes, so COVID-19 is now turning out to be more of a cardiovascular disease with multi-system involvement. I was trying to figure out in my mind which specialties or subspecialties are most involved with this disease process. Or of course, the most prominent aspect of this disease is the COVID pneumonia. In my mind, the different subspecialties involved include a pulmonologist, critical care doctor, an infectious disease doctor, a nephrologist, and very frequently a cardiologist. So I think we all know that this disease affects patients with pre-existing condition more. You know, the adverse events and mortality is higher in patients who are older and have a higher incidence of prevalence of hypertension, diabetes, etc. Some of it could be because of just reduced cardiovascular reserve. But I think a lot of it also has to do with how the virus gets into the body and the mechanisms that it affects. So the ACE2 receptor that we have heard about was discovered in 2003. So ACE2 receptor was not known when I was in medical school or when I was in training. But it turns out we are all very familiar with the renin-angiotensin system. Renin gets produced by the JG cells in the kidneys, and then it converts angiotensinogen to angiotensin 1, and angiotensin 1 gets converted in the lungs to angiotensin 2. But angiotensin 2 works on the ACE1 receptor. And ACE1 receptor, and by acting on that receptor, angiotensin 2 brings about vasoconstriction, remodeling of the heart, fibrosis, and thrombosis. Now, ACE inhibitors and ACE receptor blockers, they counteract that mechanism, but the role of the ACE2 receptor is to actually bind to angiotensin 2 and convert it into angiotensin 1,7, which is a vasodilator and has the opposite effects that are opposite to angiotensin 2. So there is a balance between angiotensin 1,7 and angiotensin 1, which determines the vascular tone. So the SARS-CoV-19 COVID-2 virus actually uses this receptor to get inside the cells. The ACE2 receptor is widely distributed in the body, in the heart, the alveolar cells, in the vascular endothelium, kidneys, GI tract. So the manifestations can be, we know that this illness can be very varied. You know, pneumonia is one aspect of it, but we have seen patients coming in with GI symptoms, patients coming in with strokes, patients coming in with acute MIs. I had a 36-year-old fellow who had severe thrombocytosis and transient coronary thrombosis. So it does affect the coagulation system. We have seen patients with DVTs and pulmonary embolism, not only large macroscopic emboli, but also microemboli. And D-dimer has been known to be an adverse indicator. So I think it is the balance between ACE2 receptor and the activity of the ACE1 receptor that this virus affects. And you know, now if you keep this in mind, it would be very understandable that older patients with endothelial dysfunction, vascular disease, hypertension, diabetes are more susceptible. Now, there has been a discussion about what to do with ACE inhibitors and ARBs. A lot of these patients are on these medicines. So there was a theoretical concern that being on these medicines increases the expression of the ACE2 receptor and provides more binding sites for the virus to get affected. But that has so far been a theoretical concern. There is also information that the expression of the ACE2 receptor is suppressed in acute lung injury and in ARDS. And expression of this receptor can actually be protective. And ACE inhibitors can tamp down the other vasoconstrictive aspect, vasoconstrictive arm. This whole interaction between ACE2 receptor and ACE1 receptor and the SARS-CoV-19 virus, it was very nicely illustrated in an article, a review article in New England Journal of Medicine a few months ago. Unfortunately, I'm not able to display that diagram, but the consensus statement from various organizations, including AHA, American Heart Association, American College of Cardiology, European Heart Association, has been to continue with ACE inhibitors and ARBs unless they need to be stopped for some other reason. So for example, if somebody is hypotensive, is in shock, has acute kidney injury, then of course you have no choice but to stop them. But for mildly symptomatic patients who are stable otherwise, the medicine should be continued is what the position paper is. And the second aspect that I would like to share is that there is a renewed interest in full dose anticoagulation in these patients, especially with elevated D dimers. Full dose anticoagulation, there is some single center reports that actually that does reduce mortality in both ventilated and non-ventilated patients. And one final aspect thing that I would like to share is that a lot of these patients, when you actually do the COVID-19 test on them, the test turns out to be negative.
Exactly.
So it looks like COVID-19 or some manifestations of COVID-19, but then the test is negative. Now, one other thing that we have also seen is that what about your bread and butter acute MIs and acute coronary syndromes? We have seen an increase in the mortality of those things. The factors may be many. It may be that patients and hospitals are just, patients are afraid to go to the hospital with the fear of contracting COVID-19. They just stay at home and come in only when complications happen. And hospitals at a certain point were also overwhelmed by the number of cases, etc. So it could have been a combination of these two factors, but the mortality of every other medical condition, including acute coronary syndromes, cancers, acute abdominal problems, everything else has gone up because of the COVID-19 phenomena.
Thank you so much, Dr. Allen.
Thank you very much. Thank you.
My next request would be to Dr. Atar Ahmed Saeed.
Like I was saying, I work as a gastroenterologist in a district hospital, but I have been interested in the recent epidemic, both in this country as well as in Pakistan. And I've tried to stay up to date with what is called the non-pharmaceutical interventions in dealing with this problem. So I'll actually see if I can share my screen. So this is Universal Healthcare Symposium in 2019, which I tried to organize last year with the help of Dr. Gondal, and many of you did participate, including Faisal, if he's still there, and Madam Yasmin. So R0, I hope you can still see my screen. It is also called R, or the reproduction number. Can you see that and hear me?
Yes, we can absolutely see that.
So R0 is the reproduction number, or it is the average number of secondary cases which each case would generate. And this is how you can actually reduce people from spreading the epidemic. It is called NPIs, or non-pharmaceutical interventions, which include social distancing, case isolation, home quarantine, and public closures, by which we mean closure of schools, universities, and workplaces. This is what is known as social distancing. This has been defined by the UK government. It was put into place in the middle of the third week of March. So you avoid contact with anybody who has symptoms. You avoid public transport unless it is absolutely essential. If possible, you work from home, and you avoid large and small gatherings, which can include sports events, for example, and religious gatherings as well. And you avoid gathering with friends and family, and use the telephone or online services. So this is the key paper. I will try and put the link into the chat part of this webinar so that you can look at it. This is a very important paper. This is what's transformed the policy of dealing with the pandemic in the UK as well as in the US. And I'm actually pretty sure in Pakistan as well. They looked at it and they formulated their social distancing SOPs as well as the lockdown in Pakistan and actually I'm sure in India and Bangladesh as well. So there are two possible things you can do. One is mitigation, in which the R is greater than 1. In this policy, you don't try to actually suppress the epidemic, you just try to slow it down or flatten the curve. You let the pandemic run its course. You hope that most of the people who are susceptible will eventually become infected and immune, and you protect those who are vulnerable. For example, in the UK, people over 70 years of age and those with underlying health conditions. And the idea is also what is called the herd immunity, that most people who have not had the infection get the infection, they're relatively fit and well, they get the antibodies, and they don't spread the infections to others. And those are the people who are vulnerable people whom you protect during the course of the epidemic. And this is the second strategy, which is called suppression, which means that the R or R naught is less than 1. Each person who's infected passes on the infection to less than one other person, which means that the infection can be on the decline, and eventually, if this continues, it will die out in this community. And so that this is also a case for what we call the lockdown, in addition to the other measures of social distancing that I have mentioned. So till the middle of March, the UK government and the Department of Health were working on the mitigation strategy. In the middle of March, they did their calculations again, and they found that if they continued with the mitigation strategy, there will be about half a million people would die in the country. So they switched almost overnight to the suppression strategy. They calculated that with this strategy, they would come to about less than 20,000 deaths, and there would be a severe economic and social cost, which is understandable, and which is obviously what we have been concerned about in Pakistan as well. And the another thing is that after you stop the suppression, the disease will come back. So this is the total number of lab confirmed cases in the UK. And this will show you that actually we are approaching now about 160,000 mark. This strategy was put in place in the middle of March, third week of March. And now in the beginning of June, we have reached about 160,000 lab confirmed cases. And this is the daily number of lab confirmed cases. As you can see, the number is declining. The red line is the rolling weekly average. And whereas at the top of the epidemic, we were averaging about 4,500 to 5,000 new infections every day. Now it is less than 500. This is the total number of COVID-associated deaths. Unfortunately, we have crossed 40,000 marks. So it is one of the highest per million mortality rate in the world. So that there are many questions to be asked about the UK and the US strategy, and whether we did all we could when there was still time. And I think this is the question that we need to ask seriously in Pakistan as well. And especially in comparison to the East Asian countries, which include China, especially in Wuhan, Hong Kong, Taiwan, South Korea, and also New Zealand and Australia. I think we have much to learn from others' mistakes, and also from other people who have taken very wise and timely steps. This is the daily additional COVID-associated death by date reported. There are variations because of the number is not as much over the weekends, but at the moment we are averaging about 300 deaths per day. Still very high, but you can see that it is down from nearly 1,200 deaths per day in the middle of April. So this is how the R naught is behaving. You can probably see that the British number is less than 1. It is 0.88. Comparison between May 24th and May 31, the rate has gone up from 0.84, but it is still less than 1, although there is already concern expressed by the epidemiologists. You can also see on this slide that the number of R naught for Pakistan is 1.82, which is actually quite high. It is higher than India and higher than Bangladesh, and it would suggest that the worst is yet to come. We have not seen the peak yet, unfortunately. And if you take the doubling time as 5 days to 1 week, then I think in 1 or 2 weeks' time, we are heading for real trouble in Pakistan. So this is just an explanation of what happens when you employ the suppression strategy. You can see the if you do nothing, which is the black line, the epidemic will peak and then subside, and people will develop immunity. And over the period of the year, you will not have another recurrence of the epidemic. But as soon as you lift the lockdown, it will come back again, which is the green line that you see. And the orange line is one where you suppress and then you actually take measures, for example, social distancing, case isolation, home quarantine, etc., so that when the epidemic comes back, it stays in control and your healthcare system is overwhelmed, and you still have the ventilators and critical care beds and hospital spaces. So what do you do at that point? This is another strategy which you can practice. It may be very relevant for Pakistan, which is that you actually have a trigger points. For example, if you have 100 ITU beds occupied, for example, in Lahore, or maybe 300 all across Pakistan, you trigger a lockdown. And so that's the on trigger. And when the critical care bed occupation starts falling, for example, it goes below 50, you open the lockdown. And that keeps on happening. The advantage of this strategy is that you can control the income, the influx of patients, and the hospital system is not overrun. But the downside is that it will require a very prolonged intermittent lockdown over a period of maybe a couple of years. So these are the lessons from Pakistan. This is my last slide. Can we do another lockdown because of, I think, what is imminent and a very large scale increase in the epidemic numbers? Whether we should continue with the non-pharmaceutical interventions with lockdown triggers, which was the last slide that you saw. We have to have central planning so that all decisions that we make are, made in one place for the whole country and implemented in the whole country. This is something which Faisal Sultan earlier addressed. We have to have effective enforcement, and we have to deal with non-executive activism, I think, including some religious constituencies as well as misplaced judicial activism. And we have to do the capacity building, which means that we have to test and adopt a test and trace policy and develop facilities for that, as well as mobile app solutions. I thank you very much.
So can you contribute upon this, on what Dr. Saeed has said?
Thank you very much, Dr. Shabir, for giving me this opportunity to comment on this very important topic that Dr. Saeed Saab has presented so well. Actually, we have calculated our basic reproduction number for Pakistan, and I am really thankful to my leader, Professor Khalid Masood Gondal, who has nominated me as the member of the Apex Committee. And I was invited by the Chief Minister to present the slides about the strategy that should be available for people of Punjab, because after 18th Amendment, it is basically the provincial subject. And what we are doing in each province, it is being coordinated by NCOC. And we are very lucky that Dr. Faisal Sultan is also here. Dr. Faisal Sultan is one of the member of NCOC, that is National Command and Operating Committee, that has almost daily meetings with all the chief secretaries and the secretaries, health experts, and we daily meet and present our findings, because R naught, or the basic reproduction number, as told by Dr. Saeed, it is not a fixed number. It continuously keep on changing. And the most important thing is that we are looking is in the effective reproduction number. The effective reproduction number depends upon the susceptible population. Whenever we talk about different numbers, we always looking forward what are the predictive disease modeling, because all our NPIs or non-pharmacological interventions depend upon these numbers. In every context, that is very important, that research has to be done at that place or in that region. What Dr. Atar Saeed has presented, that is beautiful about Pakistan, but it is based on the confirmed numbers that are given on the basis of the test, and the test can be changed. It can be less one day, it can be more one day. So there is a bias about the test. We have done actual sampling that is in field. We have taken our CR model that is susceptible, exposed, infected, and recovered. We have removed all those numbers that have those deaths. And we have also done a research that is again under the leadership of our Vice Chancellor, Professor Khalid Masood Gondal. It is one of the largest epidemiological research data that has ever been collected in Punjab and Pakistan. It is more than 1,100 people who are in different places, and more than 11,000 doctors who are giving their services for COVID-19 pandemic patients. They have responded to that data. So all our calculations are based on the real data that is available from Pakistan and Punjab. On that basis, we have concluded our short-term predictive modeling as well as long-term predictive modeling. In the short-term predictive modeling, we have presented even to our Apex committee as well as to NCOC that in June in Pakistan, especially in we would have more than 75,000 confirmed cases, and we are having more than 1 lakh cases in June, and then we would have a plateau that would remain for 2 months up till September, and we would have more than 1,75,000 patients in that plateau. After that, the pandemic will change into endemic, and we would be seeing how this pandemic swiftly changes to endemic stage, because the herd immunity, it may occur after 8 to 12 months if we don't have the vaccination, and we have the current transmission rate that we have calculated for Pakistan on the basis of real data. However, if we have the vaccination, as we have received some good news from different countries that they are in the phase of development of the vaccine, then the herd immunity would be the safest option, and we can have the herd immunity in next few months. And even we can get the herd immunity in the safest possible way. However, we have to look forward towards the recovered patients. One of the good thing about Pakistan is that as an epidemiologist, we always look towards the virulence, and the virulence is calculated on the basis of deaths as well as the basis of the admissions in ICUs. The mortality rate is still not more than 2%, and that is far less than US or UK. So it is one of, again, a good sign that the virulence of this virus, as far as epidemiology is concerned, is not as lethal, as virulent as we have seen in UK and US. The second important thing is, as far as international collaborations have been considered, that the guidelines that we have made, and we have distributed it through technical working group to the government of Punjab. Again, I want to thank our Vice Chancellor, Professor Khalid Masood Gondal, who has given his input, as well as the APNA Merit. They have given us very important documents that should be considered before going to that guidelines. And one of those documents were about how the UK was able to mitigate or suppress that curve that was very high at one time. So there are learning lessons, as this is an unprecedented pandemic, COVID-19, and that has taken up by the governments as a challenge. Now we need solidarity. We have to stand together. We have to share our knowledge, our experience to mitigate this very important pandemic. Thank you very much.
You're so right. You're so right. Dr. Talal, we'll go to you. You are working as orthopedic surgeon in the University of Tabuk. How do you feel that the surgery has been affected by this virus in your institute, the surgical and allied departments?
Well, as you see that we are, as surgeons, we're the second line, not the first line. All those esteemed colleagues who have been talking about what they have gone through, what they're going through, we feel it, but we are not at the head of the cannon. But our surgery, as a lot of surgeons, general surgeons, orthopedic surgeons, different kind of surgeons, we operate, and some of us are doing private business, and we don't want to be affected by closing our clinics. But at the same time, you see, the public are not very aware of should they go or should they not go, and if he's infected or not, he doesn't care, he just goes to the hospital, especially when there was a lockdown. Most of the people felt that they were doing nothing, so it's an excuse of getting out of the house and going and seeing your doctor. So a lot of elective cases that we got, some of them were affected, and they affected a lot of people. So there was a scare of, are the doctors going to get affected? Yes, some of them did get affected, surgeons. And so we started procedures of how doing it. Of course, we're a small village in this big world, this community of this world. So we started stopping all elective procedures. Semi-elective were stopped. Outpatient clinics were stopped. So we just stayed on the emergency clinics, emergency departments, and follow-ups. Then the issue came of what kind of patients are we going to operate on if they need surgery? Should we screen them or we should not screen them? Now, because of the limitation of the screening kits and the time it takes, and there's a controversy like the Dutch Orthopedic Association, they said, no, you should. And in Singapore, they said, yeah, you should. So we started doing, okay, only those patients who are going under GA, they should be screened. Then the other issue started of post-operatively. Are they going to occupy ICU beds or not? Because the crunch is in the ICU beds, not the normal wards. So the patients who are going to need ICU beds, or they're going to occupy ICU beds, we do not operate on them or try to postpone them. So we try to minimize and help our brothers who are the surgeons and the physicians who are in the front line. How can we help them? By not overburdening them. Then as physicians or as surgeons, how do we protect ourselves? We have to change our habits, how we go home. Do we mix with our family, with our children? No, we stop that. You have to try not to mix. The minute you go home, take out your fit, have a shower, try not to mix with your children or wife too much. If you are diagnosed or suspicion of diagnosed, then you should really stay at home and stay away from very close relatives. So the things have like curbed the spread. But again, like
no doubt the world has changed, exactly.
Yes, yes.
And
yes.
I'll share with you one of the experiences which our professor of orthopedics, I don't know whether he's on board or not, Professor Dilawes Nadeem said that the load on the orthopedics had decreased during the lockdown because people were not coming out. So this was what he shared with us regarding the orthopedic patients we were saving at our institute. So thank you so much, Dr. Dalal, for your
pleasure. It's my pleasure.
For your informative.
It's my pleasure. I'm an honor to talk this group.
बहुत शुक्रिया.
आपका भी बहुत शुक्रिया. Thank you very much.
Now we go to Dr. Sami Al-Kindi. You are an ENT surgeon and working at the College of Medicine, Taif University. Sir, what is your experience regarding ENT? Because this is a disease starting from the ENT. So what is your experience regarding the crisis?
As Dr. Salam, first of all, Assalamu alaikum to everybody. I'm really happy to be among you all. Actually, as Talal said, that we are not in the front line. So we are not exposed to the first, we are not first attenders, as you call it. However, when it started all over, the Ministry of Health, especially in Saudi Arabia, they tended to make certain regulations guidelines. For example, they constituted one hospital as a center for collecting all the infected cases to treat them, while the others are a standby. to treat all the, all the outpatients were suspended. Elective cases were suspended as well, except for the emergency cases. And being an ENT surgeon, you see, and regarding the way we are exposed or dealing with patients, they are very close in contact with patients. They are very at high risk. And I have a couple of friends who had the same thing, and they actually, my acquaintance, they passed away because of this. Now, what I want to emphasize here actually is that we as a surgeon and doctor as a general, we are taking care of patients as casual. Like we don't take the precautions as required. Either there's infection or there's no infection. Is there pandemic or there's no endemic? Because all patients who come to us, we don't know how they are. What's the background? We don't take the precautions required. For us, all the doctors need to do that. And based on that, that's why we saw the frontliners or the doctors who are close in contact with patients, they got infected, some got cured, and some got, they just got passed away. So the moral of the story is that we will consider all patients are infected until proven otherwise. Either we have this endemic or we don't have. And regarding all this, guidelines and the masks and the gloves and some of them is very ridiculous guidelines. Like for example, you're not supposed to touch your face. I don't know how can that be done. Regarding the mask and gloves and all, although there are guidelines by the government and it's implemented, like there's a penalty. If you don't put a mask, you get 1,000 Saudi Riyal as a penalty in Saudi Arabia. The thing is that we don't have enough masks. I went to the pharmacy this morning, yes, and they're out of stock. It's not possible. We have to find other ways of preventing all this thing, and which should be cheaper and applicable.
Thank you so much, sir, for joining. What experience would you share regarding the patients you are coming across in your practice?
Thank you for the invitation, and I must thank my friend Professor Gondal as well, and all the other dignitaries that I can see, some of them on the screen. It's a pleasure to be here, and thank you for inviting me. And also, I'm very impressed with this webinar and the things that we heard from various specialists and various speakers. It has been very illuminating. So I work in acute medicine, which is the front of the hospital, and I work in southwest of England, where luckily we didn't have the surge that they had in London. But we've been very lucky that we kind of created two streams within the hospital, people suspected with COVID and people not suspected with COVID. And we managed to contain it. There's you heard about the policy of the UK government from our colleague, and he explained how the government controlled social distancing and lockdown. I think that was very, very effective in flattening the curve, as you've seen here from his slides. And one thing that I observed in this country was that general public kind of listened to the advice, scientific advice, and they didn't need any fine of several hundred riyals or rupees or anything. And people generally, if you go out for a walk, if you're walking on one side of the street, the other people would walk on the other side of the street. And that kind of social awareness has been very, very helpful. In terms of management, so I'm one of the lucky ones because I caught COVID very early on. Actually, I was in Pakistan for Pakistan Society for Internal Medicine for a seminar, and I rushed back. And within 2 weeks, I was ill with COVID. Luckily, I got away with relatively mild symptoms and recovered quite quickly. At that time, the test was not widely available, but I just had my antibody test, which has come out positive today, actually. So the overall management, we heard about the oxygen therapy, role of ECMO is at the other extreme end, which UK has employed very well. We heard about one of the Pakistani doctors who recovered from it. Tufail is there, I can see, and he was participating in treating him. but rest of things, there's nothing specific that I would like to add, except for the educating the public. And I'm not qualified to comment what's happening in Pakistan, but I'm really, really, really worried about what is going on in Ramadan and Eid, Chand Raat and all that. And I'm holding my breath for this to explode. I don't know whether the figures are correct. I've heard very positive things from Faisal and from Madam Yasmin Rashid, but have all my family in Pakistan, all my siblings in Pakistan, and otherwise worrying about our homeland. And I remain greatly concerned about the way it has been handled. But thank you very much. This kind of seminar, informing people, informing doctors, sharing knowledge is very, very helpful. And thank you for inviting me.
Thank you so much. Again, patriotism, we can see in your speech, and you are in UK, but you contracted the virus from Pakistan. So we're very happy that you came out of it without any complications. Alhamdulillah. We have Dr. Majid Naeem Gondal with us. He is President, Australian Association of Pakistani Professionals. And I know it's beyond, I think, 2 o'clock in Australia. We are very grateful to you, sir, for being with us. Can you share your experience regarding Australia about the virus and the patients you're coming across in your family practice?
Much, Professor Bilqis, and thank you very much, Professor Khalid Masood Gondal, for taking this initiative to hold this webinar, which is really a good learning experience for all of us. But from Australian perspective, I want to share with you that Australia is one of those countries which actually currently is at the stage. I would like to take on from Dr. Atar Saeed's talk that he was talking about suppression. Now, Australia actually has moved on from suppression to release and then to restore. And I want to share that how Australia managed this pandemic of COVID-19. They actually adopted 4 policies, which I would be even happy to share with Professor Khalid Masood Gondal. First of all, they were listening to the experts, and they have a national committee, and then in every state, they have the regional committees. Second was that they actually had international border closure and very strict quarantine policy. And the third factor, which actually to me was very crucial, was public acceptance and social distancing. And this is actually where I want to share my experience that people here in Melbourne, they were genuinely following that rule of like not more than 2 people were getting together in house, even not more than 5 people were allowed, and people were genuinely following that advice. And the last thing, which even I was very happy to see with the efforts of Professor Khalid Masood Gondal and their team, was telehealth. Even in Australia, actually, the whole burden was shifted to the telehealth. They have more telehealth consults, and actually they increase the capacity of the public to have the services at their, without visiting the clinic. And then they were isolating people at early stages. Even they established fewer clinics in every community. So that was something which they followed, that 4-step policy. And then now currently Australia has moved on from suppression to release. Release means now they have started using restrictions, and the next stage will be restoration of normal activities. And I just want to share you that the total number of cases in Australia was total 7,055. And today there were only 4 cases. And out of 7,255 cases, there are only 463 active cases. And you will be happy to hear there are only 461 are having mild condition, and 2 are the patients who are a little bit serious. So Australia is almost out of that pandemic. And I would like to thank you and Professor Khalid Masood Gondal for holding this webinar. And I'm happy to collaborate on behalf of Australian Association of Pakistani Professionals to share our experience. We can share our knowledge and things which can help Pakistan and KEMU.
So much, sir. We are very lucky to have President KEMCANA and President KEMCA UK with us. But before we go to them, I think we are now approaching the most important segment of today's webinar. All of us who are on the screen have faces of anxiety, apprehension. Today we came across a very sad news of a probable case of depression due to isolation in Chicago of a young, apparently very cheerful and an active boy and son of our very dear colleagues. So I'll request Dr. Ali Madi Hashmi. He's a graduate of King Edward Medical University and he did his psychiatric training at Baylor College of Medicine in Houston, Texas. Dr. Ali Madi Hashmi, what is your input regarding this disease? This is the most important segment, I think, of today's webinar, and we want you to throw light on your experience.
Thank you, Professor Bilkis. Can you hear me okay?
Yeah. It's perfect.
So just very quickly, because I know we're running short of time, I'll just run through in just the next couple of minutes. I'll just run through some points regarding the mental health aspects of COVID-19. Like our certain colleagues that we just heard from Saudi Arabia, we're not in the front lines of COVID-19 as such. We're not working in intensive care units or in emergencies, but the mental health needs related to COVID-19 are extremely important for a number of reasons. Number one, mental health services and the burden of mental illnesses were extremely high in Pakistan and all over the world actually before COVID even hit. And then with the onset of the lockdown in Pakistan and the economic dislocation, the fear, anxiety, panic, depression, all of that the incidence of that is rising sharply. We are primarily concerned, King Edward has taken a lead under the leadership of our Vice Chancellor in working especially with our healthcare professionals. And since Lahore is now in the middle of the pandemic, in the epicenter of the worst cases, so we are primarily concerned about three different groups of people who are being affected by mental health problems, starting with our healthcare professionals. So we just heard from Professor Kamran Chima just a few minutes ago, and my very dear friend Dr. Iqbal Hussain, intensivist at PKLI, is on the conference call also. So the intensive care people, the medicine people, the emergency people are now having to face decisions which are extremely stressful, such as who to put on a ventilator, who not to put on a ventilator. We heard from Professor Kamran Chima about how many of the patients who are in ICUs are short of breath, they are dying, and the doctors have to deal with that on a daily basis. So there's a lot of stress, a lot of anxiety, a lot of depression related to healthcare professionals. Of course, corona patients and their families are extremely stressed out. And the general public, especially here in Lahore and all over Pakistan, are having a lot of problems with anxiety, depression symptoms. Healthcare workers specifically are at very high risk of mental health problems related to COVID for a number of reasons. We heard about things like being isolated if you are tested for COVID positive, not being able to be close to your family members. Dr. Kamran Chima used a very nice term called compassion fatigue or touch deprivation. And we are well aware now, this is not under debate now, that untreated mental health issues, including anxiety and depression, stress, sleep problems, can lead to medical illness and complications from medical illness. So our healthcare workers who are maybe sleep deprived, maybe anxious, maybe depressed, whatever, are being affected because their mental health problems are not being addressed. They're becoming more susceptible to COVID infections because of their untreated mental health issues. And this is apart from COVID patients or from the general public. One way to deal with that effectively is, of course, through our telemedicine unit, which the Governor of Punjab, Chaudhry Mohammad Sarwar Sahab, inaugurated a couple of months ago under the guidance of Professor Gondal, our Vice Chancellor. And we have started a telepsychiatry service at King Edward. It's been operational since the early days of the lockdown. And we are continuing to try and expand that service across King Edward. And then we would like, of course, to expand it across Lahore, across Pakistan, and all of Punjab and all of Pakistan if need be. And of course, one way to overcome that isolation in the ICU, the patients who are alone, the communication problems, is through telemedicine, telehealth technology, smartphone, video calls for patients, all that. We heard from Dr. Faisal Sultan that we have some infrastructure problems. We don't have internet connection. We don't have all those technologies that are needed to deliver telehealth services. But if you make a commitment to that at an institution level, city level, provincial level, then all of those can be overcome while at the same time protecting our healthcare workforce, especially the younger generation of our healthcare workforce, the people who have to take the healthcare system, our healthcare system into the next 20, 30, 40 years from complications of COVID. So just quickly, I'll mention that King Edward Medical University has been collaborating with both the World Health Organization and the Ministry of Health Regulation Services and Coordination as well as the Higher Education Commission and the Government of Punjab Specialized Healthcare Department, conducting trainings in psychological first aid. And we just had a training today actually for all of the psychiatry residents of all the teaching departments of all of Lahore. Because we feel, and Dr. Bilgis, you're aware of this, that we've done those trainings in Mayo for your unit and for other units also. It's extremely important that we provide that psychosocial support for our frontline healthcare workers, for those working in the emergency room, those working in intensive care units, all of that. And we need to do that on a recurring basis until such a time that our cases begin to and perhaps decline. The nature of COVID, the amount of panic and fear and global nature of the illness is also going to mean that going forward for the next 3 to 6 months and then several years from now, we'll need more mental health services, not just for our doctors, not just for COVID and affected patients and their families, but for the general public as well. And psychological first aid and those services are a way to provide mental health services to the general population and spread the specialist services that psychiatrists can provide across a much wider area than psychiatrists themselves would be able to do, because of course psychiatrists are limited in number, and this is also not just a Pakistani problem, it's a global problem. In the UK, in the USA, in Australia, psychiatrists are very difficult to find, and since we are specialists, we can train other GPs, we can train basic health workers, we can train even the lay public to provide basic mental health interventions, and that provides a much broader net of mental health services. And just the last point I'd like to make is that King Edward, under the guidance of Professor Gondal and our academic council and the Honorable Health Minister, has several researches that we are doing on telepsychiatry, COVID-19, the effect of COVID-19 on mental health services, mental health effects in healthcare workers. So we'll be coming out with those papers over the next few weeks, and that will give us a better idea of what the situation on the ground is in terms of the mental health effects of COVID-19 in our healthcare workforce, and hopefully also in our general public. Thank you.
We are very lucky to have Major General Muhammad Aslam Sahab with us.
Speaker said virulence of the virus in Pakistan is low. That is a research point. Has anybody researched that virulence of the virus in Pakistan is low, really? So that is one of the research topics. And then Dr. Chima said about the ventilators, that ventilator role is not that overwhelming as compared to oxygen therapy. My point is there is a dire need to train the medical staff to use the ventilators. Otherwise, this will be not optimally utilized, which is very expensive. And then concerning research, even in the international market, in the Lancet, even HCQ, hydroxychloroquine, article has been retreated. And there are 1 or 2 articles which are going to be retreated in a couple of weeks' time more. So that is, and then there is a lot of exuberant commercialization of development of vaccines by various pharmaceutical firms. Now, the masses will be misled by these wrong, so there need to be a body in the government of Pakistan or in the provinces to rebut these ideas very much on time. Otherwise, people will go in the blackmailing of the pharmaceutical companies and of the researchers. And then in the print media and on TV screens, and then in the social media, there is fake or false notifications on the letterheads which are fake. So there need to be somebody in the government to attend these wrong notifications and to clarify those, to give the right information to the people at very right time. And then there are research bodies like Wellcome Research Grant and in Pakistan, PHRC and PSF and HEC and some others. Now the researchers for MSc, MPhil and PhD, right, they need to make research projects in the area of this COVID-19 and then their traits, and then their variations in the country, and then even the concept for the public health, the concept of mitigation and suppression, and then they can do the survey and going for research. Because these days, 75% of the research in Pakistan money and international is going to be focused on COVID-19. Even an average research project will gain the research grant in COVID-19 area than in any other aspect. So it is a high time to convert this challenge into an opportunity to go for the research grants. Thank you very much indeed. Thank you.
Thank you so much, sir. PKLI is playing a very important role, especially where ICUs and HTU facilities are concerned.
Sure. Thank you for having me here, and thank you, Dr. Gondal, for giving me opportunity. I've been up since 4 o'clock, so I really appreciate you gave me time to talk about a few things. I really love the talk of Dr. Atta Saeed, and rightly so what Dr. Hashmi has mentioned. I'll talk about it. And I'll briefly talk about the ECMO that I have experience with ECMO. I want to raise a few questions. We talk about, the mortality 2%. That is true. When we did our data search, actually it is 1.8 because we were getting non-symptomatic cases in our hospital, and we did the data search on about 110 patients. But the question is, how much is the mortality of a sicker ones in the hospital? And how much is the mortality of those patients who are in ICU but not on the vent? And how much is the mortality of those patients who go on the vent in Pakistan? That is the question that we need to ask. So the data that we have crunched so far has been about 49 days. We ran our ICU department, and we started slow. We are the transplant hospital. We did not have the experience how to run the COVID. So our non-vented ICU mortality is about 30% here. Our vented mortality is 50%. And if you ask me what is the one key factor is responsible for this much mortality, it's not the ventilator. It is the nursing care. It's the training of the nursing staff. It's the training of the medical officers and the registrars. Last week, I can tell you I had the most difficult week of my career. I spent 27 hours with my team at the bedside. On each ventilator, I had to spend 45 minutes just to figure out what type of settings I need to use. So when I started my week, Tuesday last week, I intubated 4 patients. And what Dr. Hashmi was mentioning, how the stress feel like, I can tell you, when you are in the boxing court, get punched right, left, and there's no room for rest. You go out for the next round. You go out for the next round. And that's what I felt. So on the front, we got punched by the disease. On the back, our colleagues were getting sick. We had our own family members, relatives. So when you come home, you get the messages from your friends and colleagues, what to do, what not to do. So I won't take much of your time. I wanted to share some numbers. I would say that our threshold for intubation is very high. I want to share with all of my colleagues, there are 2 reasons for intubations. And I agree with Dr. Chima on that. One, if there's a perfusion problem, lactate is going up. Number 2, if the GCS, Glasgow Coma Scale, is low. Otherwise, SATs of 80, we don't intubate. So our average SOFA score is about 5 on non-intubated patients. On intubated ones, about 8 or 9. All of them, they require most of the time vasopressors, and they are very sick. So far, we have 32 patients in the ICU. Our overall mortality was about 30% on non-vented. So pretty much good number of patients they recovered. So last, I want to finish the do's and don'ts We are not using hydroxychloroquine. We did not. We have not used plasma. Primarily, it's not that we don't want to. It's primarily for the patients who have the low disease or moderate disease, mild or moderate disease. And the third, we are not going to use remdesivir. It's not that we are against remdesivir. It's for the early phase. It's very expensive. In a country like Pakistan, we need to decide, it just reduces the viral shedding from 14 to 10 days. So someone who has too many family members who are exposed, elderly in the family, and you can afford it, yes, why not? So what do we use at our ICU? We do proning, everyone. Everyone gets proning. Agar nahi ho rahi proning, to dant padegi. So that's one thing. Number two, happy hypoxia. SAT-80, if you're not symptomatic, perfusion is fine, GS is fine, you're not intubating. And then the third thing about TOSI. Tocilizumab we have used in about 50% of the cases. Out of 32 ICU cases, we used on 16. The survival so far on those patients, 16 patients, 7 of them, they did not survive. So it's about 50-50. So a lot of talk about tocilizumab. I think we have to really diagnose cytokine release syndrome, because not many people, they are actually aware of that. We have to use it early before they go on the vent, and this is where it's going to make difference. We have submitted our research protocol, and it's been approved, and we are waiting for the basically draft. So it has been approved by our IRB. So with this, last thing about ECMO, I do feel that in the whole country, except in the armed forces institution, there's no one in the private sector is doing ECMO. And this is alarming, because if someone who can afford and has a young one, or we should have some ECMO service. It's a quality indicator of an institution who's able to do ECMO. And there's no one. I mean, from Karachi, Aha, until Pindi, Islamabad, no one is doing that, because you need to develop services. And I'll end my brief session is that we need to train our staff. We are a group of 3 intensivists, and if we get the CPSP approval for, it was rejected last year. I have no clue why. We are a bunch of qualified, trained intensivists. I do think that we can train our young ones. We have hardly less than 100 intensivists in the entire country. So this is very important that on this forum, I would like to raise that we should get the young training staff that we can able to transmit what we have learned. Thank you very much.
Dr. Mohammed Faiz,
yes, I'm there. We are waiting for
thank you so much.
President.
Thank you so much.
Okay.
Thank you so
much. Thank you very much. I will be very brief. So just 2 points really. The first point is I would like to congratulate you all, really, especially at KEMU, for establishment of telemedicine. I think that has been a wonderful thing for you, and I should congratulate you as much as I can. And you should not let it go. You should use it even in future, even in post-COVID area. In UK, we have started thinking about any positives we got out of coronavirus. And this is one of the very much positive thing. And not only during the COVID season, but also post-COVID. And we should not let any good crisis go to waste and get benefit from that. So congratulations again. The second point, I'm a pulmonologist by profession, and I echo views of Professor Kamran Chima very much, and also Dr. Iqbal. Really, what I have been hearing from Pakistan is about ECMO, ventilators, tocilizumab, plasma exchange, and all those things. I mean, as far as the medicines are concerned, they are still in trials. There is no proven benefit of any of these medicines significantly, I'm afraid. At government level, I think they have to think about more basics like patient's education and getting some just basics like oxygen, non-invasive ventilation, as Dr. Kabal is saying, that mortality with non-invasive ventilation is only 30%. Loads of CPAPs, oxygen, and in our unit we have used it. I mean, for patients who are even for ITU, to start them on CPAP, and many of them, 70–80% of them do very well, and they avoid intubation. So that is one thing. I think the initial data coming from China implying early intubation, I don't think that was that correct. And so that is what I will say really, just to get our basics right. Thank you very much.
President Kimkana. Thank you very much for the donations from Kimkana.
Basically, over here, I'm internal medicine. We are just mostly doing telemedicine. So I'm not much in contact, but obviously we are keeping an eye on people who are frontline servers for like in hospitals, in ICU. But I was hearing Dr. Fauci yesterday that overall the United States is a very big country and we are seeing a plateau already. But you know, we're not out of danger, but because the death rate and the admission rate in our hospitals where I work in Virginia has reduced. But until there is a development of vaccine, because as you know, by early July, their phase 3 trials are going to be held. But still, having said all this, social distancing is the most important thing, which is really keeping out most of the people out of trouble. But as you see in America, people have started to, you know, go out there on pools, they're meeting, and with the riots happening, this social distancing is also not being affected. But I myself, I'm also taking a lot of precautions of not meeting people, not people letting come in to clean or cook in my house. So this is the situation. It's getting better, but we might see some surges and in Pakistan that social distancing is the thing really. Other things like, I don't know, you know, we don't have any 100% answer even in treatment. And that's all I can say, you know. And I know Dr. Gondal and King Edward Medical University and Mayo Hospital are doing a great, great job. Our young doctors are, you know, they are treating and there's a big load of this and the resources are not that much, but I'm very thankful for you guys that you are taking care in this heat and in this weather, you know, and that's all we can say, and we can just pray and take the precautions and the guidelines what the CDC is doing.
Exactly.
That's all.
Exactly. Thank you so much. This brings us to the end of this prestigious session. We have had a wonderful talk and we have gained so much from so many people. And we are grateful for everybody who stayed with us for, you know, almost, I think, almost 3 hours. We're grateful to each and every esteemed member of this group. And just excuse me.
Gondal, Assalamu alaikum, Dr.
I'll now request.
I want to ask something from Dr. Gondal.
Yeah, sure.
Regarding, we started doing elective surgeries.
I think, instead of answering me, our chairman, Department of Surgery, Professor Asghar Naqi, is online. I will shift your question to Professor Asghar Naqi to respond about the elective surgery. Over to Professor Asghar Naqi.
Okay.
Thank you, sir. Dr. Samia, we are not conducting any elective surgeries at present. We are only providing the emergency surgical services. And one of the major reasons is that we have converted our surgical wards, at least half of them, into corona wards. And we also shifted the emergency department, and we are providing all our services under one roof in the surgical tower. So at present, we are not providing any elective surgery except those malignancies which have been taken care of by neoadjuvant therapies, and now they are ready for their surgical resections. So at that time, they are being treated as semi-urgent, and we are only doing otherwise only emergency surgeries, no electives. And I don't foresee in the foreseeable future that in the next couple of weeks or a month, we would be able to start with our electives. Thank you, Professor Bilkis. So on behalf of the university, on behalf of the academic council, the faculty, the national faculty, Bilkis in a great manner, and for arranging such an informative webinar. And I hope and pray that this would increase our knowledge and would help in improving our patient care of the COVID-19. And I hope that this kind of activity would continue in future so that we can exchange our ideas, we can have this flow of information, we can have definitive guidelines and protocols to manage these patients to the best of our ability. So I thank you all once again. Thank you very much.
And they sacrifice their life, and I think this sacrifice is worth mentioning. और इसमें जज्बात का इजहार शायद अपनी लैंग्वेज में बेहतर अंदाज में किया जा सकता है, जिस अंदाज में हमारे डॉक्टर, हमारी नर्सेज, हमारी पैरामेडिक्स खिदमात सर अंजाम दे रहे हैं एक कोविड पेशेंट के पास और पॉजिटिव पेशेंट के पास जाके पीपी में दिन गुजारना, रात गुजारना एक काफ़ी मुश्किल काम है, लेकिन दे आर डूइंग, क्योंकि जो ओथ उन्होंने they took up the oath in their final prof, इस वक्त उस oath की practical shape में वो नजर आ रहे हैं. And inshallah, I believe as a nation, हमारे medical profession, हमारी government, हमारा media, हमारी अवाम एक पेज पे होकर as a nation will come up, ये जो वबाई मर्ज है इसका तदारक हम कर सकेंगे. और इसमें प्रोफेसर बिल्किस आपका भी मैं बहुत मशकूर हूँ. और इस वक्त वो हमारे जो कोलीग्स हैं, जो हमारे बच्चे हैं, जो हमारे दोस्त हैं, जो हमारी नर्सेज और पैरामेडिक्स और एडमिनिस्ट्रेशन के लोग हैं, पाकिस्तान से और दुनिया भर से जो ईमान के साथ इस दुनिया से जा चुके हैं, हम उन तमाम के लिए दुआए मग़फ़िरत करते हैं. और मैं ये समझता हूँ कि जितने पार्टिसिपेंट इस वक्त मौजूद हैं वो एक मरतबा सूरत फातिहा और 3 मरतबा सूरत अखलास पढ़ के उनकी मग़फ़िरत के लिए दुआ करें. वो इस रास्ते के शहीद हैं और इंशाअल्लाह अल्लाह पाक इस शहादत की वजह उनको जन्नतुल फिरदौस में जगह अता फरमाएंगे और उनकी कुर्बानियां रंग लाएंगी. और ये पाकिस्तान और पाकिस्तान की अवाम बहुत जल्द इस वबाई मर्ज से जो निजात हासिल करेंगी. सो बिस्मिल्लाहिर्रहमानिर्रहीम, अल्हम्दुलिल्लाहि रब्बिल आलमीन अर्रहमानिर्रहीम मालिकि यौमिद्दीन, इय्याका नअबुदु व इय्याका नस्तईन, इहदिनस सिरातल मुस्तक़ीम सिरातल लज़ीना अनअमता अलैहिम गैरिल मग़दूबि अलैहिम वलद्दाल्लीन. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. اللهم اغفر لحينا وميتنا وشاهدنا وغائبنا وصغيرنا وكبيرنا وذكرنا وأنثانا. اللهم من أحييته منا فأحييه الإسلام ومن توفيته منا فتوفه على الإيمان. या अल्लाह पाक इस कोविड में जो हमारे मेडिकल प्रोफेशन के लोग, हमारी नर्सेज, हमारे पैरामेडिक्स, हमारी इंतज़ामिया के, हमारी अफवाज के अवाम जो इसमें आप इंतकाल कर चुके हैं, रुतबा शहादत हासिल कर चुके हैं, या अल्लाह उनको जन्नतुल फिरदौस के आला मकाम में जगह अता फरमाइए और उनके लवाहिकीन को सब्र जमील अता फरमाइए. और या अल्लाह या अल्लाह हम आपसे तौबा और इस्तिग़फ़ार करते हैं अपने गुनाहों की, आप हमें और उम्मत को माफ़ फरमा दीजिए. और या अल्लाह पाक जो इस राह में आपके पास जा चुके हैं, रुतबा शहादत हासिल कर चुके हैं, उनको जन्नतुल फिरदौस के आला मकामात में जगह अता फरमाइए और लवाहिकीन को सब्र जमील अता फरमाइए. और या अल्लाह हमें और इस मुल्क को और पूरी दुनिया को इस वबाई मर्ज से जल्दी या अल्लाह और फौरी एक छुटकारा अता फरमाइयो और ये दुनिया और ये मुल्क एक पहले की तरह सुकून वाली रहने वाली जगह बन जाए और वो रौनकें और वो सुकून उसी तरह वापस आ जाए. और जो भी अहबाब इसमें कंट्रीब्यूट कर रहे हैं उनको दुनिया और आखिरत की कामयाबियां नसीब फरमाइयो. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursaleen walhamdulillahi rabbil alamin. Ameen.